Shall I start now? Yeah. Good morning, dear friends. As far as the CVS is concerned, what are all the topics that we are? For any undergrad, the following topics are very, very important. What are those topics? You all know that fetal circulation is an important notes aspect. Second one is some criteria with respect to heart. Second one is fetal circulation. Third one is certain criteria we have to. Fourth one is cyanotic congenital heart. Fifth one, acyanotic congenital heart disease. Fifth one, rheumatic fever, infective endocarditis, Kawasaki disease, and then finally, these are all the topics that we are in short notes as well as essay. And I am going to teach you how to approach a case of cyanotic congenital approach. Cyanotic congenital is based on the simple algorithm. Okay. Are you ready, my dear kids? To start, to start with, going to deal with the first one is fetal circle. Fetal circle. What about the fetal circle? What about this fetal circle? Remember, you have lungs after birth, but in fetus it is inactive. You have liver after birth, but it is inactive in fetus. Both these actions are taken care. So I don't want liver functionally but not structurally. I don't want lung functionally but structurally I will have. So what will happen? God has given two things. One is ductus venosus to bypass liver. Second one is ductus arteriosus to bypass lung. This is the simple concept. After birth, this is before birth. This is before birth. After birth, ductus will close, venosus will close, and blood will flow through liver. After birth, ductus arteriosus close and blood will flow through. This is the basic simple concept. So fetal circulation should always be begin with this manner in your HCA. Now let's go to the circulation, right? To go to the circulation. So follow me carefully. The oxygenated blood from the plasma, oxygenated blood from the placenta comes out through the umbilical vein. What vein comes out through the umbilical, and from this umbilical vein it goes into the So umbilical vein carries oxygenated blood. Umbilical vein carries oxygenated blood from pleasant. And instead of going into the liver, it bypasses liver through ductus bypasses liver through ductus venosus, and from there it joins the inferior vena cava. There it joins the inferior vena cava. Remember, this inferior vena cava is also receiving blood from the lower limbs. Also receives blood from the lower limbs, as a result of which the saturation that reaches the right atrium will be less compared to the umbilical vein, because here in umbilical vein receives pure oxygenated blood from the placenta, whereas before it reaches the right atrium it also receives deoxygenated blood from the inferior vena cava. So that is from the lower limbs. So here you have your, but majority your inferior vena cava that drains into right atrium has got an oxygenated. This oxygenated blood reaches the right, and from the right atrium you all know that the blood that comes to the right atrium through the inferior vena cava will go to the right ventricle, but that is after birth, but this is before birth. So what will happen, the blood that comes to the right atrium is an oxygenated blood, so instead of going into the right ventricle, it traverses across the patent foramen ovale. It traverses across the patent foramen ovale and reaches the left atrium. And reaches the left atrium. And from the left atrium, it reaches the left ventricle. From the left atrium, it reaches the left ventricle. From the left ventricle, it goes out through the aorta. It goes out through the aorta. And from the aorta, three supplies. You have your coronary artery, carotid artery, subclave. Coronary artery, carotid artery, subclave. So coronary artery is for heart. Carotid artery is subclavian artery is for. So what happens? The upper part of the body, your head, thorax, limbs, your heart, this is predominantly oxygenated blood. What? Oxygenated blood. Okay. So after giving these three branches, continues as descending aorta. It continues as descending aorta, and from the descending aorta, so look at this, descending aorta comes down, descending aorta comes down, and descending aorta divides into two branches. Descending aorta divides into two branches and supplies the lower limbs. Supplies the lower limbs, and finally it is divided into two umbilical arteries. Two umbilical arteries which carries deoxygenated blood to the, it carries deoxygenated blood to the placenta. So this is one part of circulation. Deoxygenated blood to the placenta. This is one part of circulation. Right. This is one part of circulation. The second circulation. This is with respect to oxygenated blood. As what happens in case of deoxygenated blood, the blood from, so that is blue color, that is blue color. Look at this, the blood from the SVC, the deoxygenated blood that gets collected from the upper limb, thorax and head and neck will come to the superior vena cava, and from the superior vena cava it goes into the right atrium. It goes into the right atrium, and this is the deoxygenated blood, and from the right atrium it comes to the right ventricle. From the right atrium it comes to the right ventricle, and from the right ventricle to the pulmonary artery. It goes out through the pulmonary artery. But remember, almost 90% of the blood that reaches the pulmonary artery, well, that reaches the pulmonary artery, instead of going into the lungs, only 10% will go to the lungs, but majority of the, only 10% will go to the lungs. This 10% will go to the lungs, but majority of the blood from the pulmonary artery crosses the ductus arteriosus, bypasses the ductus arteriosus, and reaches the descending aorta. and reaches the descending aorta. I repeat, it reaches the descending aorta, and you all know that descending aorta contains blood from the arch of aorta as well as blood from the superior vena cava indirectly through right atrium and right ventricle. Okay, so what happens? The upper predominantly oxygenated blood reaching your head, neck, thorax, heart, upper limb. Predominantly they receive oxygenated blood, whereas lower limb receives deoxygenated blood preference. And is this a parallel circuit or serial circuit? This is nothing but a, what is this? Is this a parallel circuit or serial circuit? This is parallel circuit. Okay, so this is called fetal circulation of the fetal circulation. So what are all the three inputs to the heart? The three inputs to the heart are, one is IVC, second one is SVC, third one is pulmonary vein. Almost 70% IVC, oxygenated blood, 20% deoxygenated blood, and remaining 5% comes through the pulmonary vein. I told you almost 90% of the blood from the pulmonary artery reaches the lung. Only 10% reaches the lung. So these, some amount of blood that reaches the lung from the pulmonary artery comes out from the lung in the form of pulmonary, in the route of pulmonary vein, and joins the left atrium Okay, right. So the predominant input to the heart is IVC 70%, SVC 20%, and pulmonary vein 5%. Pulmonary vein 5%. This is very, 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 very important. So these are all the things that we had explained here. Okay, explained here. So as I told you, the upper part of the body predominantly contains good blood, and lower part of the body predominantly some amount of deoxygenated blood. Okay, so SVC 20 to 25% of venous return. Your IVC, okay, your SVC 25%, IVC 75%. And the descending aorta, as I told you already, it's divided into two umbilical arteries. 65% divides into umbilical artery. The remaining 35% supplies the lower limb. So this is with respect to fetal circulation. After birth, ductus arteriosus. Can anyone tell me where ductus arteriosus closes? Ductus arteriosus closes by 24 to 48 hours functionally because of increased O2 content. Because lung starts functioning. That is your first cry. Ductus arteriosus. So ductus arteriosus, two questions can be asked. One is functional closure and one is cell closure. Functional closure usually takes place by 1.5 days, whereas anatomical closure usually occurs by 10 days. And then ductus venosus closes by 14 to 21. So this is all about fetal circulation. So a small revision. Okay, I think you will tolerate this small revision. Let me see how much time I am going to take for this small revision on fetal circulation. Listen to me carefully. Time starts. So oxygenated blood from the oxygenated blood comes from the placenta through the umbilical vein, and it reaches the liver, and it bypasses the liver by means of ductus venosus, and then it reaches the right atrium. Okay, through inferior vena. In the inferior vena cava, deoxygenated blood from the lower limb also joins. As a result of which, saturation of the blood that reaches the right atrium is less compared to the saturation that is present in the umbilical vein. So from the right atrium, it goes to the left atrium through patent foramen ovale, from left atrium to left ventricle, aorta, and then ascending aorta, arch of aorta, three branches: carotid artery, coronary artery, subclavian artery, and then it continues as descending aorta. So upper part of the body preferentially receives oxygenated blood, whereas another circulation. What is another circulation? The deoxygenated blood from the head, neck, thorax comes through the SVC, goes to the right atrium, and from the right atrium it goes to the right ventricle, and from the pulmonary artery goes to the pulmonary artery, and from the pulmonary artery almost 90 to 95% bypasses the pulmonary artery and bypasses the lungs through ductus arteriosus and reaches the descending aorta, right? The remaining 5 to 10% goes to the lung. Instead of getting oxygenated, it comes through the lung and it drains into left atrium through pulmonary vein. 75% inferior vena cava, venous return to the heart. 20 to 22% SVC, remaining 5% pulmonary vein. Okay, pulmonary descending aorta, and then descending aorta divides into two: 65%, 35. 65%, okay, divides into umbilical artery and reaches the placenta, whereas 35% supplies the lower limb. Rectus arteriosus functional closure takes place by first day, 1.5 days, whereas anatomical closure takes place by 10 days, whereas rectus venosus takes anatomical closure about 14 to 21 days. That's all. Fetal circulation is over and the time taken is just 1 minute and 20 seconds. Right? Okay, clear? Clear, my dear friends? So this is about fetal circulation. 1 second. So my children right now are clear with the topic on fetal circulation. Let's go to the second. So what is the second question? The second question is, some criteria. Some criteria. What are all the, so first question is, the second question is, what are all the criteria that we follow in case of in case of CVS, particularly with respect to pediatrics. So is this correct? Okay. So Jones criteria is meant for rheumatic fever. Duke's criteria is for infective endocarditis. Nada's criteria is for congenital heart disease, and Keith Edward criteria for pulmonary hypertension. Keith Edward criteria for pulmonary hypertension. Okay, Duke's criteria for infective endocarditis, Jones criteria for rheumatic fever, Nada's criteria to assess a child with congenital heart disease, and Heath Edward classification for pulmonary vascular disease, that is pulmonary hypertension. This can be asked as a short. Okay, now let's go to concentrate on congenital heart disease. We are going to concentrate on congenital heart disease. Okay, baby, ready? Okay, so congenital heart disease, what is that criteria called? That criteria is called Nada's criteria. Is that criteria? Nada's criteria. Okay, so as far as Nada's criteria is concerned, we have, so what do you mean by this criteria? Without taking an echo, how do you confirm that child has some kind of congenital heart disease? Major criteria, minor criteria. Nada says that you need to have one major criteria or two minor criteria. Nada's criteria is a short. What are all the major criteria? The child is having cyanosis, can be a congenital heart disease. The child is having congestive cardiomegaly. What do you mean by congestive cardiomegaly? The heart rate will be more, the respiratory rate will be more, there will be cardiomegaly, and there will be hepatomegaly. Hepato, and the baby will be having suck, rest, suck. Baby will having suck, rest, suck. This is about congenital, the presence of congestive cardiac failure, the manifestations of congestive cardiac, and then presence of a diastolic murmur of any gradient. Doesn't mean that you need to have grade 3 or 4. Even presence of grade 1 diastolic murmur, it comes under major criteria in NADAS. That is, it means that the child is having some kind of congenital artery. Systolic murmur of grade 3. Systolic murmur of grade 3, then you can ask. Presence of diastolic murmur itself, any grade comes under major criteria. But systolic murmur of grade 3 or 4 only comes under major criteria. Why systolic murmur of grade 1 and 2 doesn't come under major criteria? The answer is very, 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 very simple. Even in severe anemia, even in severe anemia, you have in decrease in viscosity, so increase in velocity, as a result of which you can have hemic murmur in anemia. That's why only systolic murmur of grade 3 or 4 comes under major criteria. What are all the minor criteria? The minor criteria are systolic murmur of grade 3, grade 1 and 2. 3 and 4 comes under major criteria, 1 and 2 comes under minor criteria. Abnormal ECG, abnormal X-ray, abnormal BP. Abnormal ECG, abnormal X-ray, and abnormal ECG, X-ray, BP. Okay, and then abnormal S2. Abnormal S2. So let me explain these things in short. Abnormal 1, S2. As far as S2 is concerned, yes, you have A2 and P. You have A2 and P, which is very well heard during, which is very well be heard during inspiration. Okay. So when you have wide and fixed S2, wide and fixed S2 split, remember this can be, okay, please remember the abnormal S2 itself here, short notes for you. Wide and fixed S2 split comes in AST, whereas wide and variables, wide and variable split occurs in VST. As paradoxical split, paradoxical split, that means you can hear during expiration but not in inspiration. Paradoxical split occurs in patent ductus, patent ductus, single S2, single S2, S2. You can hear in single S2, you can hear in severe aortic stenosis or severe pulmonary stenosis. Severe aortic stenosis or severe pulmonary stenosis. So these are all the questions that can be asked with respect to S2. S2 sound itself is here short notes for wide and fixed split, wide and variable split, paradoxical split, single S2. These are all the things that they will be expecting you. Then, okay, then. So with respect to S2, okay. Then with respect to ECG. So let me tell you how to read an ECG with respect to congenital heart disease. So normally this is, let me say, lead 1, lead 2, lead 3. This is the normal pattern of QRS count. Why lead 2? Lead 2 has got tall R waves because current flows from 11 o'clock to 5 o'clock towards lead. That's why lead 2 has got maximum voltage. What happens in left axis deviation? Left axis deviation, left ventricle undergoes hypertrophy in this direction. So what will happen? Current can, instead of flowing from 11 o'clock to 5 o'clock position, will move from 11 o'clock to 3 o'clock position towards lead 1. So what will happen? Lead 1 will have tall, and the lead 3 will have lead 3, that is towards the right. The lead which is kept over right arm. So the waves predominantly moves away from the direction of lead that is kept over the right arm. So what will happen? You will get negative waves. You will get negative waves. So what will happen? Here tall R wave in lead 1 and negative S wave in lead 3. So this is left axis deviation. This is left axis deviation. Now what is right axis deviation? Right axis deviation is nothing but, look here, right axis deviation means your right ventricle undergoes hypertrophy. That means the right ventricle will undergo hypertrophy in this direction. So current flowing from, instead of flowing from 11 o'clock to 5 o'clock, it will flow from 11 o'clock to 9 o'clock position towards the right limb, towards the right limb. So what will happen? Towards the right limb. So what will happen? Current predominantly move towards lead 3, away from lead 1. Whenever current flows towards one particular lead, you will have a positive voltage. So lead 3 will have a tall R. So lead 3 will have a tall R wave. Whereas lead 1, it goes away from lead 1. So lead 1 will have a predominant S wave. Predominant S wave. So this is called as right axis deviation. What are all the causes for right axis deviation or right ventricular hypertrophy? Very, very simple. The causes of RVH are, one is pulmonary stenosis, second one is pulmonary hypertension. Pulmonary stenosis, pulmonary hypertension. For you, this is more than enough. Pulmonary atresia. What are all the causes for left axis deviation? You have aortic stenosis and then systemic hypertension. Aortic stenosis and systemic hypertension. So with this is with respect to ECG. What is normal axis? What is left axis? What is right axis? These are all the things you need to know. Okay, second point. Third, what are all the, then you need to know normally chest leads. So normally this is V1 and V2, V3, V4, all know V5, V6. So what does it mean? In V1 and V2, the R waves are small because V1 and V2 are kept over right ventricle. Whereas V3 and V4 has got little bit taller R waves because it is facing over the septum whose muscle mass is large compared to the right ventricle. And V5 and V6 has got further taller R waves because the left ventricular mass is more compared to septum. So the height of the R wave is proportional to the muscle mass. I have a very bad muscle mass. That's why this is called progressive. This is called progressive R wave increase in. This is not. But what will happen in case of right ventricular hypertrophy? In case of right ventricular hypertrophy, you will have tall R wave in V1 and V2 and deep S wave in so tall R wave which is unlikely normally in V1 V2 and deep S waves in V5 V6 means this is right ventricular hypertrophy, whereas right ventricular hypertrophy. Whereas in case of left ventricular hypertrophy, what will happen? You have very tall R wave in V5 V6, tall R wave in V5 V6, whereas deep S waves in V1 and V2. This indicates left ventricular hypertrophy. This indicates left ventricular hypertrophy. And finally, what is this? Normally, you have, look at this, V3 and V4, R wave is taller compared to S wave. But in V3, V4, if you have a wave like this in V3 and V4, you have a wave like this. So what does it mean? R wave amplitude is equal to S wave. R wave equal to S wave in amplitude. R wave is equal to S wave. So this is called equiphasic. This is called equiphasic R and S in V3 and V4. So what does it mean? When in V3 and V4, equal amplitude waves on the right side indicates right ventricular hypertrophy. Tall S waves, tall waves on both right on the right side as well as the left side. That's why it is called, has got equiphasive R and S wave. This equiphasive R and S wave is called as Catch-Vactal phenomenon. This is called as Catch-Vactal phenomenon, suggestive of biventricular hyper. Suggestive of, this is called biventricular hyper. Okay, this is called biventricular hypertrophy. So this is with respect to ECG. So please remember simple concepts of ECG for pediatric congenital heart, and you need to remember abnormal S2, right? So what are all the, so Nadaskar X-ray as what with respect to BP, I will show you. With respect to BP, how can we diagnose? With respect to BP, how we are going to diagnose? Let me, okay, instead of BP, let me say pulses. You have two brachial pulses. You have two, this is very interesting. You have two brachial pulses. Okay, and then you have two femoral pulses. Femoral pulse. Okay, brachial pulses you palpate here. Femoral pulses over the femoral area. So you have right, left, upper limb, lower limb. Okay, upper limb, lower limb. Upper limb means brachial. Lower limb means femoral. Right? So when you have both brachials present but femorals, so what is this? This is called coarctation of, this is called coarctation of ion. First. Second one, right, left. So brachial, you have right brachial filled, but rest of the things are absent. That is left brachial, right femoral, left femoral. All these are all absent. So what is this? This is called interrupted aortic. This is called interrupted aortic. And then you have, so brachialis, femoral, right, left, all are absent. So no pulses are felt. When no pulses are felt, you need to look for two things. One is carotid bruit present. Carotid bruit present. Carotid bruit absent. Carotid bruit present means it is a case of critical aortic stenosis. It is a case of critical aortic stenosis. Whereas carotid bruit absent means it is called hypoplastic left heart syndrome. What is that? This is called hypoplastic left heart syndrome. So this is with respect to, instead of saying BP, I am teaching you with respect to how to approach a case of congenital heart disease with the help of femoral, that is lower limb, and brachial pulse, and then brachial pulses. This is very easy. So look here, when all pulses are present, the child is said to be normal, no obstructive disease. When both femorals are absent, coarctation of. When both femorals and left brachial is absent, interrupted aorta. When no pulses are felt, then look for carotid bruit. When carotid bruit is present, obstruct critical aortic stent. When there is no carotid bruit, the left ventricle muscle mass is poor congenitally, that is called hypoplastic left heart syndrome. Right? Hypoplastic left heart syndrome. Right? So this is how you approach a case based on the four limb pulse. I have in one paper from one of the university, they have asked you how to approach congenital heart disease based on four limb pulses. You write this, you will get good marks. Right. Now I am going to teach you congenital heart disease. What are all the things you need to know? Listen carefully. So broadly, congenital heart disease is classified as please listen carefully. Broadly, congenital heart disease is classified as one is cyanotic congenital heart disease. Cyanotic congenital heart disease. Second one is acyanotic congenital heart disease. In cyanotic congenital heart disease and acyanotic congenital heart disease. In cyanotic congenital heart disease, you divide into two. One is increased pulmonary blood flow, another is decreased pulmonary blood flow. What are all the conditions that are associated with increased pulmonary blood flow? They are transposition of great arteries. Second one is truncus arteriosus. Third one is total anomalous pulmonary venous connection. Third one is total anomalous pulmonary venous connection. As conditions that are associated with reduced pulmonary blood flow are tetralogy of fallot, okay, tricuspid atresia, and then Ebstein's anomaly. These are all the diseases associated with decreased pulmonary blood flow. What do you mean by cyanotic congenital heart disease? They are nothing but blue baby. They are nothing but blue baby. They usually present with discoloration of hips and discoloration. What is central cyanosis? What is mean by this is called central cyanosis. That is bluish discoloration of lips. Bluish discoloration. Okay, blue baby. What is mean by acyanotic congenital heart disease? This acyanotic, so this is cyanotic congenital heart disease. What is called acyanotic congenital heart disease? Let me explain. Okay, now we have acyanotic congenital heart disease. These are all pink babies, usually present with breathlessness. Usually present with breathlessness. Okay, increased breathing. Acyanotic. In acyanotic congenital heart disease, you divide into two. One is obstructive lesions. Obstructive lesion. Second one is left to right. Second one is left to right. Obstructive means you have aortic stenosis. Aortic stenosis. Second one is coarctation. Coarctation of aorta. Left to right shunt means you have at the level of atrium AST, at the level of ventricle VST, at the level of great vessels, that is PDA, patent ductus arteriosus. Patent ductus arteriosus. Okay, so what is the manifestation of this obstructive lesions? Blood to the systemic circulation will be absent. So invariably, child will present as shock. Shock immediately or after second or third day when the ductus arteriosus closes is the main manifestation of obstructive obstructive lesions. Obstructive lesions often present as shock in case of critical aortic stenosis by third day or fourth day after birth because of absence of systemic circulation. Whereas Coarctation of aorta usually presents with what? Absence of blood supply to the lower limb invariably leads to claudication. So the main manifestation of obstructive lesions are either shock or in infancy, or you can have claudication. You can have claudication of lower limbs. Again, it is due to lack of poor blood supply to the lower limbs. Whereas ASD, VSD, and PDA. What are all the manifestations of ASD, VSD, and PDA? One, they can be asymptomatic. Simple murmur you can hear. They will be asymptomatic. Only incidentally detected murmur you can have on asymptomatic. The child will be otherwise normal. Going for some LRI, the doctor would have diagnosed some systolic murmur here, some systolic murmur here, from continuous murmur here. In that way, they can diagnose. Second one is when the shunt is very large, it will lead to pulmonary congestion. This pulmonary congestion can lead to recurrent pneumonia, can lead to recurrent, okay, and it can lead to congestive cardiac failure. You all know that. The pulmonary vessels are meant for uh, is meant for low pressure circulation. When more and more blood flow from the left side of the heart to the right side of the heart to the lung, what will happen? The pulmonary vascular endothelium will undergo hypertrophy and they will go for pulmonary hypertension. When pulmonary hypertension occurs, blood instead of going from left ventricle to right ventricle, left side of the heart to right side of the heart, because of severe pulmonary hypertension, blood will come from right side to left side, leading to cyanosis. This is called Eisenmenger syndrome. This is called Eisenmenger syndrome. This is called Eisenmenger syndrome. So, what is mean by Eisenmenger syndrome? CCF goes and cyanosis comes. This is called Eisenmenger syndrome. Usually untreated ASD, untreated VSD, untreated PDA will go for this Eisenmenger syndrome. For example, PDA will develop cyanosis by about 10 years, VSD by about 20 to 30 years, and ASD by about 40 years. ASD by about 40 years. So this is the simple classification of congenital heart disease. I repeat, cyanotic congenital heart disease, increased pulmonary blood flow, decreased pulmonary blood flow, they are blue babies. Okay, it is divided into TGA, truncus arteriosus, total anomalous pulmonary venous connection. Increased pulmonary. Decreased pulmonary blood flow is characterized by tetralogy of fallot, tricuspid atresia, and Ebstein. Acyanotic congenital heart disease are called pink babies. They divided into obstructive lesions and then left to right shunt. Obstructive lesion usually presents with claudication of lower limbs or shock in infancy. Examples are coarctation of aorta or aortic stenosis. Whereas left to right shunt presents as asymptomatic recurrent pneumonia, congestive cardiac failure, Eisenmenger syndrome, and when it is untreated, they can go for cyanosis. Right? So, okay, then what is the next thing that my children should need to learn? Very, very important. Hyperoxia test. I have seen almost all the universities so far asked this hyperoxia test. Can anyone tell me what is called hyperoxia test? Hyperoxia test. Very, very important for you. Hyperoxia. So, what is this hyperoxia test? When the baby is born, cyanosis. The baby is born with cyanosis. It can be congenital heart disease, cardiac, it can be respiratory. Respiratory. Okay. How to know whether it is due to cardiac or respiratory? Very, very simple. One, for the cyanosis to occur in respiratory, you will have severe retraction. One method is severe retractions. The accessory muscles are acting means severe retraction. Present means respiratory. Absent means cardiac. This is a simple thing that you need to know. So, but what is hyperoxia test? So, a child is cyanotic. A child is cyanotic. You give 100% oxygen for about 10 minutes. So, after giving 100% oxygen, look for PO2, partial pressure of oxygen. If PO2 increases, it is pulmonary. It is pulmonary. It is pulmonary. So this is hyperoxia test pass. Hyperoxia test pass. Pass means pulmonary. Pass means pulmonary. As when your PO2 doesn't rise or falls, doesn't rise, then it is hyperoxia test fail. Test fail. Then this failed hyperoxia test is suggestive of cyanotic congenital. As soon as you see any child with failed cyanotic congenital heart disease, you need to start prostaglandin E1 analog alprostadil. This is very, 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 very important. So when any case of cyanotic congenital heart disease you saw and failed hyperoxia test, immediately you need to start prostaglandin E1 analog so that it can bypass the obstruction. And one more question often asked is, right, so what are all the questions we have covered so far? Maybe little bit heavy. What are all the questions we have covered so far? One, what are all the things we have covered? One, we have covered short fetal circulation is a long note. We have covered long notes. Short notes, hyperoxia test. Oxia test. Third, NADA's criteria, very, very important. NADA's criteria. Then fourth one, abnormal S2 is an normal. Why? How to diagnose congenital heart disease based on ECG. In ECG, I taught you left ventricular hypertrophy, right ventricular hypertrophy, left axis deviation, right axis deviation. And then with the help of four limb pulses, how to diagnose obstructive congenital heart disease. Look here, I have taught you 1, 2, 3, 4, 5, 6, 7 in the past 1 hour. We have discussed 7 basic things and 6 short notes and 1 long notes for your examining. Right? Okay. So now I am going to teach about. So what are all the 4 things I taught you? The 4 things it was taught to you are, one is congenital heart disease. So congenital heart disease, acyanotic congenital. One is obstructive. Another one is left to right shunt. In obstructive, coarctation of aorta. In left to right shunt, AST, EST. Classification of congenital heart. And then, and I repeat, the what is the presentation of this cyanotic congenital heart disease? Left to right shunt. One is asymptomatic CCF, recurrent pneumonia, Eisenmenger syndrome. Eisenmenger syndrome means cyanosis comes whereas CCF goes. Whereas obstructive lesion usually presents with shock after PDA closes or claudication. of lower limb. Now, first let us discuss today about cyanotic congenital artery. Let us discuss about cyanotic congenital artery. So, what are all the cyanotic congenital heart disease we are going to discuss? So, cyanotic congenital heart disease. That means you have failed hyperoxia test. Have failed hyperoxia test. What are all the two disorders? Increased pulmonary blood flow. In increased pulmonary blood flow, you have transposition of great arteries, total anomalous pulmonary venous current. Then you have truncus arteriosus. Whereas in decreased pulmonary blood flow, you have tetralogy of blood, tricuspid atresia, Ebstein's. What are all the main short notes? Tetralogy of fallot is a short notes. Tricuspid atresia is an MCQ, not a short notes. You will be at TGA, total anomalous. These are all the things they will ask you. I don't think you will be getting questions on truncus arteriosus. Ebstein's anomaly, you know what it is. Let me. Okay, right. Okay. Let me teach you one by one. So, with the help of, so what is this? So, can you tell me what is this? I have just shown you the X. What is this act? Look at this. There are no pulmonary blood vessels, and you have a boot-shaped heart. You have a boot-shaped heart, and you have an upturned apex. So, what are all the findings here? What are all the findings here? Look here. You have a boot-shaped heart. One. You have a boot-shaped heart. You have upturned apex. Have upturned apex. That is your apex of that doesn't touch the diaphragm. Okay, right. So this is called, and then look here, there is no pulmonary vessels. So you have pulmonary oligemia. Pulmonary oligemia. Okay, and then finally there is no heart rate size increase. Heart increase in size. No cardiomegaly. So what is this? So no pulmonary oligemia, no cardiomegaly, boot-shaped heart, apex of the heart doesn't touch the diaphragm. Normally, apex of the heart touches the diaphragm. This is called tetralogy of Fallot. So, what are all the 4 points in tetralogy of Fallot? What are all the 4 points in tetralogy of Fallot? One, you have pulmonary stenosis. They will ask you what is tetralogy of Fallot. One, you have severe pulmonary stenosis. As a result of which you have right ventricular hypertrophy. And remember, you have a large VST, and through this VST, blood from the the blood that is present in the cyanotic blood that is present in the right ventricle, instead of going across the pulmonary artery into the lung, it goes across the VST into the left ventricle and causes cyanosis. So, and in that area, aorta will be joining into that large VST. So, overriding aorta, overriding. So 4 points in very, 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 very important. 4 points in tetralogy of 4 points in tetralogy of second. So what is the manifest? Because of this, so what is the manifest? One, because of poor blood flow into the lungs, oxygenation cannot occur, leading to one cyanosis. Okay, because of that cyanosis, you have clubbing. Because of cyanosis, you have erythropoietin induction, leading to polycythemia, and you can have cyanosis, clubbing, polycythemia, and because of this, you can also have what is that? Severe cyanosis can lead to cyanotic spell, otherwise known as dead spell. So, cyanosis, clubbing, polycythemia, and then cyanotic spell. These are all the manifestations. Again, one separate question is what is called cyanotic spell? What is called cyanotic spell? Very, very important. Dead spell. I have not seen any university question without this cyanotic spell question. So look here. By by about 4 or 5 months, baby will suddenly develop an incessant cry with increased heart rate, that is tachycardia. Suddenly heart rate will increase. Suddenly respiratory rate will increase, tachypnea. Why? All because of that infundibular spasm. All because of that pulmonary stenosis will go for spasm, leading to. So normally you have, remember one thing, because of increased blood flow across the valvular stenosis, you will have ejection systolic murmur in the pulmonary area. That is one of the manifestation of tetralogy of Fallot. So what will happen in cyanotic spell? That murmur will not be heard. So reduced intensity of the murmur. The murmur will not be heard. And then what will happen? You have single S2 because severe pulmonary stenosis leading to absence of P2. Okay, and at the times the child can go for sudden death if it is not treated properly because of cerebral hypoxia. Because of what? Because of because of cerebral hypoxia. You can have sudden death because of cerebral hypoxia. So what is the treatment for? What is the treatment for cyanotic spell? What is the treatment for cyanotic spell? Okay, what is the treatment for cyanotic spell? One, you need to give oxygen. Two, you need to put the baby in knee chest position or squatting position. You need the knee chest position to increase the systemic hypertension, so that your right to left shunt. Third, so one is oxygen, second one is knee chest position, third one is you need to give morphine. Third one, you need to give morphine. Morphine reduces infundibular spasm, morphine reduces oxygen demand, morphine reduces the cry of the child. Rarely you can give phenylephrine to increase systemic phenylephrine, but very rarely we use to increase systemic hypertension, or sodium bicarb, because of severe poor oxygen supply, it can lead to metabolic acidosis. So to combat that metabolic acidosis, we used to give bicarbonate. So these are all the 5 treatment of choice, and then you need to prepare the child. So what is the treatment then? And then treatment. So what is the treatment? So the treatment of choice is always after a cyanotic spell, put the baby on beta blocker. That is propranolol, to reduce the oxygen demand by the heart itself. One is beta blocker. Second one is palliative, not palliative. So yeah, initially the child will not be in a position to withstand the surgery, but at the same time you need to increase the oxygen output to the other parts of the body. So you will do Blalock tossing shunt. What? Blalock tossing shunt. So what is Blalock tossing shunt? They will connect the subclavian artery to pulmonary artery, so that you are bypassing the stenosis. So blood instead of going into from the right ventricle to the pulmonary artery, going from the subclavian artery to the pulmonary artery to cortex. There is one port called cortex port, and then so beta blocker. This Blalock restriction should be done immediately. Be done immediately as soon as the child recovers from the cyanotic spell. Third one is corrective surgery, otherwise known as intracardiac repair. Corrective surgery, otherwise known as intracardiac repair. Okay, this is usually done at 4 months. This is usually done at 4 months. Usually done at 4 months. Intracardiac repair. So, what are all the other complications of other complications? What are all the other complications of tetralogy of Fallot? One, any child with the tetralogy of Fallot comes with altered sensorium. It means you are dealing with cerebral venous thrombosis. Cerebral venous thrombosis, because there is an underlying polycythemia, increased viscosity, reduced velocity, which was triad comes into play. Second, the child can go for hemiplegia because of an infarct. Third, surfactant A and D in the pulmonary alveoli has innate immunity. Since blood is bypassing the lung, the innate immunity is lost, and this blood that reaches the brain is not filtered off its bacteria, leading to cerebral abscess. Leading to cerebral abscess. So these are all some of the complications of what? Tetralogy of Fallot. Finally, one more important, very important thing is, will you get cardiomegaly? No, you don't get cardiomegaly. Cardiomegaly you will get only when there is increased pulmonary blood flow. Here there is decreased pulmonary blood flow, so you won't get any cardiomegaly. Okay, if at all you get cardiomegaly, what are all the things that you need to know? One, there is an associated valvular regurgitant lesion. Valvular regurgitant lesions. One. Two, there must be an infective endocarditis. Two, there can be an underlying systemic hypertension. Four, there can be an underlying severe anemia. So you won't get cardiomegaly in a case of tetralogy of Fallot. If at all you get a cardiomegaly or congestive cardiac failure, there can be an endocarditis, myocarditis. There can be an endocarditis, myocarditis, valvular regurgitant lesion, systemic blood pressure, and anemia. This is very important. Look here, I had covered the entire tetralogy of Fallot in this one slide. Tetralogy of Fallot is a damn sure questions to you. Look here, tetralogy of Fallot, what are all the four components? What are all the five manifestations of tetralogy of Fallot? What is the presentation of a cyanotic spell? How to treat a cyanotic spell? What is the treatment? Beta blocker, laloctosintion, intracardiac repair. What are all the other complications? When will you get cardiomegaly or cesium? That's all over. Almost over. Okay. Now, what is the ECG in what is the ECG in tetralogy of Fallot? You all know that you will get right ventricular hypertrophy. So, right ventricular hypertrophy means what? Right axis deviation. You get right axis deviation. So, what do you mean by right axis deviation? Right axis deviation means, as I told you already, you have lead 1, lead 2, lead 3. Right axis deviation means tall R wave in lead 1, deep S wave in lead, tall R wave in lead 3, and deep S wave in lead 1. Okay, what will happen in case of disease with respect to limb leads? What will happen in chest leads? What will happen in chest leads? V1 to V3. V1 and V2 is over right ventricle. So normally you will have short, small R wave in V1 and V2. But here right ventricular hypertrophy. So you will have tall R wave in V1 and V2, whereas deep S wave in V5, V6. So this is classical picture ECG of a tetralogy of fallot. Or ECG of a tetralogy of fallot. Right. So you will get right axis deviation, you will get right ventricular hypertrophy. Okay, then a small thing that you need to know is one more point. What is this tricuspid atresia? What is this tricuspid atresia? What is this tricuspid atresia? So here the entire right ventricle is undergo hypoplastic. So hypoplastic right ventricle. The tricuspid wall is not disease performed. So what will happen? It will produce severe cyanosis at birth. Unlike tetralogy of Fallot, in which cyanosis usually occurs by fourth month of life, severe cyanosis at birth at third day. When ductus arteriosus closes functionally. But what is the clue? Since there is no right ventricle, predominantly ECG wave will flow towards left ventricle, so that you will get left axis deviation. So simple clue, any cyanotic, any suspected cyanotic congenital heart disease plus left axis deviation is equal to tricuspid atresia unless otherwise is equal to tricuspid atresia unless otherwise. Okay, is tricuspid atresia unless otherwise proved. This 5 points is more than enough. These 5, but the only thing you need to know is cyanosis, third day or fourth day, ECG showing left axis deviation is tricuspid atresia. So what is the treatment of choice? Step 1. Any cyanotic congenital heart disease, step 1 is Blalock tossing shunt. That means you will connect subclavian artery to pulmonary artery. Second, step 2, you will connect SVC to pulmonary artery. So this is done maybe, let me say, fourth week of life. Step 2, you will connect SVC to pulmonary artery maybe fourth month of life, because predominant venous drainage to fourth month is SVC1. And then step 3, this is called fontans. This is called hemifontan. This is called hemifontan surgery, connecting SVC to IVC. Finally, step 3. So connecting IVC to pulmonary artery. This is called fontan. This usually takes place by about fourth. So these are all the simple things to remember about tricuspid atresia. Atresia. Now let me teach you about Ebstein's anomaly. So these are all the obstructive, these are all the reduced pulmonary blood flow. Now let me teach you about Ebstein's anomaly. So what is called Ebstein's anomaly? So normally, so look at this. This is the level of the so this is tricuspid valve. This is mitral valve. Anything above the level of the tricuspid valve is called as right atrium, and below the level of tricuspid valve is called right ventricle. Similarly, the chamber above the level of the mitral valve is left atrium. The chamber below the level of the mitral valve is left ventricle. What happens in case of Ebstein's anomaly? In Ebstein anomalies, there is downward displacement of, look at this, instead of being here, it goes here. Which one? Tricuspid valve. Which one? Tricuspid valve. This is called downward displacement of, this is called downward displacement of tricuspid valve. So what will happen? The amount of ventricle, the amount of chamber that is below the level of the tricuspid valve is becomes small. So right ventricle becomes small, whereas right atrium becomes large. Or else I can say some part of the right ventricle becomes atrium. Some part of right ventricle becomes atrium. So for example, let me say, so this is this is tricuspid valve. So above the level of the tricuspid valve, my finger is right atrium. Below the level of tricuspid valve, my palm is right ventricle. But when tricuspid valve descends from here to my first arrow, so what will happen? Some amount of my palm becomes a part of finger. So what happens? There is atrialization of the right ventricle. This is called Ebstein's anomaly. So this is called as what? Ebstein's anomaly. So what is called Ebstein's anomaly? So Ebstein's anomaly means atrialization of ventricle. So what is Ebstein's anomaly? I am not going to confuse you with the many points. What is Ebstein's anomaly? One, downward displacement of tricuspid valve. Only one point you need to know. Downward displacement of tricuspid valve. As a result of which, what happens? As a result of which, you will get atrialization of right ventricle. As a result of which, you will get atrialization of right ventricle. So that what will happen? You will have a very, very large atrium. So you will have huge right atrium. Because of this huge right atrium, you will have a massive large heart. Because of that, you have massive large heart, huge cardiomegaly. 4, 5, huge cardiomegaly, massive heart. And because of the stretching of the right atrium, you will have right bundle branch block. Bundle branch block. Okay, bundle branch. Okay, bundle branch block. And because of this right atrium slowly leaking blood into the right ventricle, you have a JVP, you have prominent V waves. prominent V wave. Sixth point. Seventh point. This Ebstein's anomaly, because of this tricuspid regurgitation and right bundle branch, leading to multiple heart sounds. S3, S4, everything, leading to multiple heart sounds. Another point is they are usually associated with WPW syndrome. Usually associated with WPW syndrome. Fourth, my eighth point, WPW. And remember, you have variable cyanosis. Variable cyanosis means not all patients with Ebstein's anomaly will have very low saturation. It all depends on the level of descent of the tricuspid valve. The more the descent of the tricuspid valve, earlier the cyanosis, severe the cyanosis. Lesser the descent of the tricuspid valve, mild cyanosis in a adolescent or by about 20 years, 30 years. So variable cyanosis, presentation, variable age. So this is all about Ebstein's anomaly. Ebstein's anomaly is characterized by huge massive heart. Ebstein's anomaly is characterized by huge massive heart. One more DD for this huge heart. Wall to wall heart is Pompey's disease. One more example is so what are all the points you know to about Ebstein's anomaly? Downward displacement of tricuspid valve, atrialization of right ventricle. Okay, very huge right atrium, massive large heart, right bundle branch block. JVP you have V waves. JVP you have V waves. Multiple heart sounds. WPW syndrome, variable cyanosis at variable age. Variable cyanosis and variable age. Okay, so this is with respect to Ebstein's anomaly, atrialization of ventricle. Right, atrialization of ventricle. Okay, so what are all the things I taught you? Tetralogy of fallot, tricuspid atresia, Ebstein's anomaly. Now, one more thing. What are all the things that you need to know? Another thing. Now we have what is called TGA. What is called TGA? TGA means transposition of great artery. TGA means what? Transposition of transposition of great artery. Great artery. So what are all the things you need to know about transposition of great artery? Simple. So normally aorta arises from left ventricle and pulmonary artery arises from right ventricle. But what happens in case of transposition of great arteries? In transposition of great arteries, your pulmonary artery arises from left ventricle. Aorta arises from right ventricle. This is called transposition of great arteries. Pulmonary artery arises from left ventricle and aorta arises from right ventricle. As a result of which, what will happen? Normally, heart is a serial circulation. Which will be converted into parallel circulation. Sir, what is the serial circulation and what is this parallel circulation? Very, very simple. Serial circulation means you all know that pulmonary vein drain into left atrium, normally left atrium, which in turn drains into left ventricle, which in turn drains into aorta, and aorta in turn leads to systemic circulation, and then your deoxygenated blood from SVC and IVC will drain into right atrium and then right ventricle and then pulmonary artery to lungs and then lungs to pulmonary vein. This is called serial circulation. This is called serial circulation. But what happens because of pulmonary artery arising from the left ventricle and aorta arising from the right ventricle, what happens? It becomes parallel circulation. What happens in parallel circulation? Let us see. From the left ventricle, pulmonary artery arises. This pulmonary artery goes to lungs. It gets oxygenated. It gets oxygenated. Oxygenated blood through the pulmonary veins drain into left atrium and then left ventricle, and then it goes into pulmonary artery, this circulation. Whereas from the right ventricle, it goes to aorta. Aorta it goes to systemic blood supply, and from SVC and goes to all parts SVC, IVC, SVC and IVC. From SVC and IVC, again draining into right atrium, again draining into right ventricle, very impure blood, right ventricle, and then this aorta. So here what happens? Oxygenated blood becomes more and more oxygenated, whereas deoxygenated blood becomes more and more deoxygenated. So this is called parallel circuit in case of transposition of great artery. So what happens immediately after birth? So this is pathophysiology. So what are all the manifestations? So what are all the manifestations? What are all the manifestations? Okay. So what are all the manifestations? Very simple. The manifestations are cyanosis on third day when the patent ducts are arteriosus closes. Will you have any murmur? There is, and usually they were large for date week. Large for date week. For date week. So this is the manifestation. Any child suddenly becomes cyanosis after birth, and if you don't hear any murmur means it is PGA. So what is the treatment? Step 1. There should be some amount of blood supply across the vessels. So what will happen? You need to use prostaglandin E1 analog. You need to use prostaglandin E1 analog. You need to use prostaglandin E1 analog to open the PDA. This is on day 4 or day 3. Second point. Then this ductus arteriosus is not that much enough to mix the blood. So what you need to do? You need to put a large hole in the atrium so that the oxygenated blood and deoxygenated blood that mixes with each other at the level of the atrium. So this is called balloon atrial septostomy. This is balloon atrial septostomy. The name is Rashkind balloon atrial septostomy. Okay, Rashkind balloon atrial septostomy. 3. Rashkind balloon atrial septostomy. Okay. Second one is this should be done within 4th week. But when you don't do corrective surgery, what will happen? The right ventricle will undergo hypertrophy, fails because it pushes against aorta. Right ventricle is meant for low pressure circulation pulmonary, whereas left ventricle, which is meant for high pressure, will push the blood against pulmonary artery low pressure, so it will become hypoplastic. So you need to do what? Corrective surgery. What is called corrective surgery? This is called arterial switch repair. This is called arterial switch repair. This is called Japanese arterial switch repair. This is called Japanese. So that's all. This is what you need to learn with respect to transposition of great arteries. And what will happen? Normally, aorta will be on the right and pulmonary artery will be on the left. Because of transposition of great arteries, the one will behind the other. So what will happen? You will have egg on side appearance. Egg on side appearance due to narrow trunk. Due to narrow egg on side appearance due to narrow trunk. So this is all. So what are all the 5 points that my kid needs to know with respect to transposition of great arteries? Pulmonary artery arises from the left ventricle, aorta arises from the right ventricle. The serial circulation will become parallel circulation. Cyanosis on day 3 or day 4 as the PDA closes, and on auscultation no murmur, and it is usually a large for dead babies because most often it is a complication of infant of diabetic mother. And the treatment is 3 PGE1 analog, balloon atrial septostomy, and arterial switch repair. Corrective surgery is arterial switch repair or Japanese. Okay, fine. Now, so what are all the next? So we have completed transposition of great arteries. Now, what is this? Look at this. What is this? This is called figure of 8. This is called figure of 8 or snowman appearance. So what is this disease we are going to talk about? We are going to talk about what is the thing that we are going to talk about? Very, very simple. We are going to talk about okay, total anomalous pulmonary venous connection. We are going to talk about total anomalous pulmonary venous connection. So what is the treatment? Very, very simple. 4 pulmonary veins should drain into left atrium. This is normal. What happens in total anomalous pulmonary venous connection? These 4 pulmonary veins will be draining into either superior vena cava. Then it is called supracardiac. PAPVS. Okay, superior vena cava. Or it can drain into right atrium through coronary sinus. This is called supracardiac tube. Then it can drain into right atrium. So it is called cardiac. PAPVSC. Or it can drain into IVC. Then it is called infra PAP. Most common is supracardiac. So what is the manifestation of supracardiac PAPVSC? Very simple. There, see, all pulmonary veins come to the right atrium, come to the superior vena cava, and from the superior vena cava it goes to the right atrium, and from the right atrium it goes to the left atrium through a large AST. Okay, so there is a large AST through which it goes, so that you will have a ASD like mirror. But in ASD you won't get cyanosis or you won't get any CCF. So when you get here findings of AST plus cyanosis plus CCF, it means you are dealing with a case of total anomalous pulmonary venous connection. Okay, then what about, so this is not an emergency. but not an emergency. But this infracardiac TVA PVC is an absolute surgical emergency. This is an absolute surgical emergency. Why it is an absolute surgical emergency? The answer is very, very simple. Why it is an absolute surgical emergency? Because it mimics hyaline membrane disease. Membrane disease. One. The baby will have severe pulmonary hypertension. True. It usually manifests with a triad of cyanosis, normal heart size, okay, and then ground glass lung. Because of ground glass lung. Why it is so? Pulmonary veins, if it drains into the inferior vena cava, it gets obstructed. So from the pulmonary veins, the lung is emptying oxygenated blood via the pulmonary veins into the left atrium. When all four pulmonary veins are obstructed, usually when it ends in SVC, it won't get obstructed. When it ends in coronary sinus, that is in the right atrium, it won't get obstructed. When it drains into IVC, it gets obstructed, leading to backflow of blood, pulmonary congestion, leading to pulmonary hypertension. This is an absolute surgical emergency, and surgery is the treatment of choice as soon as the diagnosis is made. Surgery should be done. Should be done. Very, very important. Absolute. So, supracardiac TAPC, AST-like features along with the cyanosis. Figure of 8 appearance is mainly due to this enlarged pulmonary veins that drain into the right atrium. That drains into the right atrium. Okay. Okay. Whereas infracardiac TAPC usually mimics hyaline membrane disease, severe pulmonary hypertension, the triad of cyanosis, normal heart structure, heart size, along with ground glass appearance. Surgery should be done immediately. Should be done immediately. That's all over. So, what are all the things we have covered so far with respect to heart diseases? We have covered tetralogy of fallot, transposition of great arteries, tricuspid atresia, total anomalous pulmonary venous connection, Ebstein's. Remember, these five things are more than enough with respect to cyanotic congenital heart disease. Apart from that, we have learnt about apart from that, we have learnt about one more thing. What? Hyperoxia test. Learnt about hyperoxia. Learnt about hyperoxia test. Okay, right. Learnt about ISO cyanotic congenital heart disease is over. So let's concentrate on acyanotic congenital heart disease. Let's concentrate on acyanotic congenital heart disease. So what are all the acyanotic congenital heart disease? Acyanotic congenital heart disease are three in number: AST, VST, P. Okay. So normally AST features are incidentally detected. You don't get that kind of murmur in AST. Because why you don't get a murmur in an AST? Because the right atrium, left atrium, when you have AST, left atrial pressure is also so, right atrial pressure is also low. So when you don't have that kind of pressure to push the blood from the left atrium to the right atrium against pressure gradient. So usually asymptomatic, usually you don't get murmur. You don't get murmur of shunt. Shunt murmur will be absent because of low pressure. Okay. Failure because of small size, because of small shunt pressure. Failure you don't get. Ostium secundum, ostium primum, and sinus venous. Look at this. This is your septum. When you have, so this is your left atrium. This is your right atrium. So when you have a hole at the topmost part, that is called sinus venosus type. So when you have a hole across in the lower part of the atrium, this is called ostium prime. When you have a hole in the central, it is called ostium secundum. Most common is ostium secundum. Okay, the sinus venosus type is closer to the atrioventricular canal. So it can be associated with cleft mitral valve. Cleft mitral valve can be associated cleft mitral valve can be associated with mitral regurgitation. Whereas your sinus venosus type can be associated with partial anomalous pulmonary venous connection. That means two pulmonary veins will be draining into left atrium, whereas another two pulmonary veins will be draining into the SVC. The blood that comes from the SVC, okay, goes into the right atrium, and what will happen? Some amount of blood will be mixing across the sinus venosus AST. So what are all the three types of AST? The three types of AST are ostium secundum middle part, ostium primum lower part, ostium sinus venosus type upper part. Sinus venosus type is associated with partial anomalous pulmonary venous connection, uh, whereas whereas ostium primum will be associated with cleft mitral valve. So this asymptomatic sinus venosus type, this asymptomatic ostium primum type, even when asymptomatic, there are associated underlying heart lesion. So even when asymptomatic, surgical correction is the route. Whereas in ostium secundum, the most common defect that is present in the central part of the atrium, the surgery is advised only after 4 years when the AST is large and fails to close. When the AST is large and fails to close. ASD is large and fails to close. Okay, right. So where you will get the murmur? As I told you already, the murmur in ASD will not be heard. The murmur in ASD will not be heard. Okay. The murmur in ASD across the shunt will not be heard. Why it is not heard? Because of the low pressure. Because of the low pressure. Whereas the amount of blood that comes across from the left atrium to right atrium and to right ventricle. So what will happen during diastole? The blood from the right atrium to right ventricle goes into the right ventricle. Also, the blood that comes from the left atrium is also loading the right ventricle. So what will happen? You will have a delayed diastolic murmur across the tricuspid area. And all the amount of blood from the SVC, right atrium as well as left atrium going into the right ventricle, and in what way all this blood will be jetted out through the small pulmonary artery, leading to ejection systolic murmur across the pulmonary wall. So in AST, you won't get shunt murmur. You will get flow murmur across the pulmonary wall. Across the pulmonary wall. Since left atrium to right ventricle, your right ventricle usually undergoes hypertrophy initially. Okay, initially. The larger the defect, more the intensity of the murmur across the pulmonary wall, not the shunt. Okay. So the chamber to increased are right atrium enlargement and right ventricle hypertrophy. So right ventricle hypertrophy is usually seen. Because of the right atrial enlargement, there will be right bundle branch block. And because of the equalization of pressure, what will happen? You will have wide and fixed S2 split as we discussed already. And because of the large pulmonary artery in fluoroscopy, you will have a hilar dance. Because of amount of blood that is gutted into the pulmonary artery, you will get hilar dance. Almost majority of the AST will close spontaneously. Usually that is less than 8 mm. Less than 8 mm. Usually they do not be associated with pulmonary hypertension. As you all know, our right atrium and right ventricle are enlarged. What is the ECG pattern? The most common type is right ventricular hypertrophy. That is the most common type is ostium secundum. Whereas in ostium primum, there is a cleft mitral valve. So there is a mitral regurgitation leading on to volume overload of the left ventricle. So you will get left axis deviation. So you will get left axis deviation. Okay. Chronically, if you don't treat, the right atrium gradually enlarges, leading to right bundle branch block, leading to atrial arrhythmias and heart failure only in late adulthood. Okay, right. Catheter closure, is it possible? Yeah, AST closure. Yes, catheter closure is possible, but surgical closure in case of sinus venosus because of associated partial anomalous pulmonary venous connection. And surgical closure is also advised in case of ostium primum. Ostium primum. So, what are all the revision points that we need to know with respect to AST? What are all the revision points that you need to know in AST? So, one revision points you note there are three common types. So, ostium secundum, ostium primum, sinus venosus type. Most common is ostium secundum. Ostium primum is associated with cleft mitral valve. Sinus venosus is associated with partial anomalous pulmonary venous connection. Ostium secundum spontaneous closure, whereas at fails more than 8 mm at 4 years surgical closure or catheter based device closure. That is called Amblatzer device. They will put one mesh over the defect of atria. Whereas ostium primum and sinus venosus, even when asymptomatic, you need to close it. Even when asymptomatic, you need to close it surgically. Okay, shunt murmur, will you get shunt murmur in AST? In ASD? No. So what is the murmur you will get in ASD? Flow murmur. Where does the flow murmur you will hear? Pulmonary area. What is the ECG pattern? RSR pattern. Why it is so? Right bundle branch. Okay, right bundle branch block. What is the first chamber to undergo hypertrophy? Right ventricular hypertrophy. What is the chamber that never undergoes hypertrophy? Left atrium never undergoes hyper. Will never undergo hyper. Okay. So, will you get CCF? Rarely. Okay. What is the late manifestation? Atrial arrhythmias in adulthood. What is the usual closure? Amblatzer catheter based closure. Catheter based closure. That's all about AST. That's all about AST. So let me finish VST also. About AST. So let me finish VST. Okay. Okay, VST. So what are all the VSTs? You have what are all the you have perimembranous VST, membranous VST. VST is a defect between right and left ventricle. You have muscular VST. Muscular VST. This perimembranous VST and muscular VST will go for spontaneous closure. Spontaneous, it can from 3 months to 3. Whereas, whereas your inlet VST in and around the tricuspid valve and your outlet VST in and around aortic valve, if it closes spontaneously, it will borrow a leaflet from tricuspid valve, or it borrow a valve from aortic valve, leading to tricuspid and aortic regurgitation. So spontaneous closure not allowed. So spontaneous closure not allowed in inlet and outlet VST. Okay, outlet VSD not allowed. So in case of membranous and muscular, wait and watch. Wait and watch. Watch. Okay, remember, but large VST causing CCF, surgery can be done, closure can be done at 4 months itself. At 4 months itself. Fifth point. Sixth point. What is the chamber that is enlarged? So, large amount of blood will flow from the left ventricle to right ventricle. So, right ventricle will undergo hypertrophy, followed by right atrium. All blood comes to the left atrium and then left ventricle. And then left ventricle. So, what is the murmur? So, small hole means, small defect means you will get pansystolic murmur. Murmur across the left sternal edge. Sternal edge. Across the left sternal edge. So, no CCF. Only huge murmur you will hear. When you have a large defect, you have small intensity murmur. But you are prone for CC. And remember, huge pressure gradient between left ventricle and right ventricle. So more prone for infective endocarditis. More prone for infective endocarditis. So what is the ECG? As I told you, biventricular hypertrophy. So that you will get equiphasic R and S wave. It is called catch-Vactal phenomenon. It was explained already. That is called catch-Vactal phenomenon. It was explained already. Okay, so this is with respect to VST. So let us revise VST. So VST often associated with failure to thrive and recurrent respiratory tract infection. Why? Because it is a largely can be perimembranous muscular closes spontaneously, outlet just below the aortic valve, inlet just below the tricuspid valve. They are more prone for what? They are more prone for uh, aortic regurgitation and pulmonary tricuspid regurgitation if it is allowed to close spontaneous. Okay, it can be a small, moderate, large VST. Smaller the size, more the murmur, less the CCF. Larger the VST, more the CCF, lesser the what is that? Shunt murmur. This pansystolic murmur across the shunt, whereas in AST it is flow murmur. Okay. So VST usually manifests with failure at the around 2 to 4 weeks and the pulmonary vascular resistance falls. Shunt murmur, as I explained already, your left atrium, left ventricle and pulmonary artery are increased in the order. More the right ventricular hypertrophy means severe the pulmonary, severe the left to right shunt. And remember, this is the most common cyanotic congenital heart disease and most common cause for infective endocarditis. So usually majority of them will close us by 3 years of life. But when you have a cyanosis, so what is this? When failure goes, cyanosis comes. As I explained, this is called Eisenmenger syndrome. It was explained to you. Eisenmenger syndrome. Catch-Vactal phenomenon is biventricular hypertrophy, as I explained to you. So it can lead to CCF, Eisenmenger syndrome, infective endocarditis. When it is allowed to close spontaneously, your inlet and outlet can lead to pulmonary, aortic, and tricuspid regurgitation. So majority of them right now we close surgically. Usually when CCF is there, it can be closed as early as possible. Can be closed as early as possible. So this is a short comment on VST. Short comment on VST. So let me finish PDA for today. 5 more minutes. PDA for today. So that left to right shunt will be over now. Over now. 5 minutes. Over. So now let's talk about patent ductus arteriosus. So what is the patent ductus arteriosus? One, it is a large vessel communicating your pulmonary artery and aorta. So this PDA is normal in preterm because usually ductus arteriosus closer after but normal in preterm, whereas abnormal in term. Abnormal in, so in term always ruled out. In term always rule out. Always rule out. What are all the things you need to rule out in term? Term baby. What syndrome? Congenital rubella syndrome. Rubella syndrome. You need to rule out in term. So what is the manifestation of PDA? Continuous murmur. Manifestation of PDA is continuous murmur. Okay, continuous murmur. So what is the treatment of PDA? So in preterm, it is a normal one. So in a preterm, you divide into two things. The child is less than 1000 grams. The child is more than 1000 grams. Less than 1000 grams means even when it is asymptomatic, the ductus they will not tolerate. Close it. Whereas more than 1000 grams, only when there is CCF, you close it. So how to close it? Medical closure. How to close it? Medical closure. What is that medical closure? Medical closure is one. Long back, people used indomethacin. Then it has been replaced by Brufen. Now even paracetamol IV can also be used. Paracetamol IV because it is prostaglandin antagonist. When you use prostaglandin antagonist, ductus arteriosus will close. Okay. Whereas in term, no medical closure. No medical closure. There is no medical closure possible. So what you need to do? In term, there is no medical closure is possible. So only, is it catheter closure? Is it a device closure? It all depends. Small, medium, large. Small means coil closure. You put a coil, open it. Medium means device closure. Very large PDA means double. You cut this in, cut this in. Double ligation. When it is done, it is usually at 1 year of age when the child attained 10 kgs. So with this, we have completed today. We have completed AST, VST, PDA, cyanotic congenital, acyanotic congenital heart disease. Almost 15 topics we have covered. So meet you soon to cover rest of the topics tomorrow, along with important topics in respiratory system. Let me complete cardiology, some remaining part of the cardiology. What is that? Coarctation of aorta, rheumatic fever, Kawasaki disease, rheumatic fever, not much, only few things, Kawasaki disease, supraventricular tachycardia. I will complete within 40 minutes tomorrow, and the entire thing with annotations will be given tomorrow. Thanks a lot for patient hearing. Bye bye.